Yeah, okay.
Hello, Dr. Basab. Good evening. Welcome to our Vidarbha,
Yeah,
Devi, Savangi, Amravati, Pusad.
Yeah, it's quite a nice mix.
Chandrapur.
And Chandrapur.
Very good evening, sir.
Hey, good evening, Dr. Shalaka. Hello, nice meeting you in person.
So Shalakha, everybody is Shalakha. So you will be, now you'll be worried how many Shalakhas there are. So on the one on the far left with long hair and yellow is Shalakha. Other are not Shalakha.
Yeah, Dr. Pushpa, I can recognize.
Hello, sir.
Hello,
Yes.
hello.
And the one,
Yeah, no, I think that the reason why it's happened is because everybody's used that link, right? That's how it is. Nobody has filled the questionnaire. I think that's the reason why the long questionnaire.
If you would have gone, if you would have gone from your own mail, then you would not have been Shalakha.
Yeah. Because and you get this long questionnaire, you keep on filling that, then you earn your own.
70 people have filled in the questionnaire, sir.
70. That's good. That's very
70.
nice. So we'll have to follow that data as it comes out. I think Ajay will be keeping that, and then we will be knowing how things are. I think everybody can change the name, no? Whoever's.
Yeah. Please change your name.
I think that would be fine. No?
I think my chosen background
from their own mail. They are their own names. Madam Pushpa ma'am, tumi change kara. Right hand side, 3 dots you will get.
No, it is
I've done
already
it for
changed.
Dr. Pushpa. I've done it for Dr. Pushpa. And
Yes, thank you, sir. Thank you.
So as long as I know who the other people are, everybody can do it themselves, I'm sure.
Thank you.
Name yourselves. Then 3 dots, as Dr. Surekha tells you, next to mute button.
3 dots right side. Drop down menu and they can rename.
So 4 talks, essentially, four discussions. The first will be, I think, Dr. Pushpa starting first with the MTP amendment.
Yes, sir. MTP amendments by Dr. Somesh, madam.
Yeah, and then I do that technologies, the abortion technology, that one is mine. Then Dr. H.O. Seva Kit, the discussion which Dr. Surekha is doing. And then the last one will be Dr. Shobha will be taking on that pre and post family planning cancer, the counseling.
Yes.
They have some new slides now. There's some recent changes in the slides they have sent recently.
I assessed the slide through the link which was sent.
Is it? There was a huge PPT, which meant a huge collection of things.
Yeah, but there were 2 videos also. I don't know who is.
Oh yeah, there were videos. Of course, there are 3 videos actually.
There are videos. So I don't know how the videos are going to be seen. One video I went on the WHO site and I could find there also.
One is 8 minutes. The one with stigmatizing language.
Yes.
The one is 2 minutes and 40 seconds is the WHO one. Let me see what this.
Right, toolkit.
Safe and unsafe abortion.
That's toolkit. That's the one which you are taking, no, Dr. Surekha?
Yeah.
Then norms and stigma. What are norms and stigma? That's a 4-minute, 20-second video. I think we should have these videos to start with. I think now till it's already 6 o'clock. I think you can put a video.
Yes, shall we start, sir? Shall we start, sir?
Of course, Dr. Shalaka, we should start. We should go ahead. So where to put the videos, Dr. Surekha? Any idea where to put videos?
See, I think we can go ahead with you.
Nee, after Dr. Pushpa, we'll go in order.
With Dr. Pushpa, and then we can have the video, I think.
Yeah, I guess we'll have one video in between each.
Right.
So something going there. Yeah. Dr. Pushpa, you can start. I think there's nobody to welcome, nobody to address, or I can give a small address, welcome to people who's there. 27. Is there anybody? There's anybody from there? We don't know how many people are supposed to join this thing. 28. We'll wait for
70 have registered.
70. So 27.
Yes, 70. So, but then we cannot wait for them to join, right?
Yeah, I guess we should start in the next 30 seconds.
Yes, we start. I think we can invite Dr. Basap to give a small introduction of the RAC.
Are we live, Meeting? Are we live? We're
Yes,
not
sir.
live.
Yes, sir.
Sorry, we're not
Yes,
live.
sir.
We are all connected with the people who we have here. So a very warm welcome to everybody joining here for Respectful Abortion Care. This is the continuing training of trainers that we are doing over the last few weeks. And this is a joint project of FOXI with WHO, where we want to take it forward. You have heard about respectful maternal care or maternity care, but this is respectful abortion care, where it involves giving women who approach us for abortion how to deal with them and how to counsel them and how to lead them and guide them in their way so that they can be having an effective abortion process, and also to help them to safeguard themselves so that they don't fall into the repetitive stage of abortion after abortion. So guiding you through, we'll be having slide decks which have been shared by us, which have been made by FOXI and WHO. And these slide decks will be run through by different presenters over the next hour and a half or nearly 2 hours. And if there's any doubts at any time after the end, please be free to clarify them, and we'll be going through. We'll be happy to answer questions. And after we finish, and also be free to put them in the chat box, because as a lot of people are talking, there'll be other people who'll be answering, and at any point of time, we'll be continuously keeping in touch with the audience. So for the first talk on MTP amendments, may I invite Dr. Pushpa. Dr. Pushpa, this is the only time I'll invite you. The next time you can invite the next speaker, and I think we can just move on that way. Okay. Thank you. Anything from Meeting? Anything? No, I think we are good to start. Dr. Pushpa, yes, the stage is yours. Thank you. Thank you.
I need to share my screen. Host, please let me share my screen.
Once a try now.
Am I audible, visible, and is my screen visible to all?
Yes, ma'am. Yes, ma'am.
Okay. So today we are meeting here to discuss something about safe abortions. And I'll be talking about the amendments which are recently made in this MTP rule. And the objective of this first module is to let all people concerned, all the stakeholders, to have knowledge regarding what are the new laws and what are the changes in the rules. Now, let us see this, why we need to discuss so much about this safe abortion. Because unsafe abortions in India, it led to not only morbidity, but even mortality, and it hampered women's and girls' full participation. As much as 8%, it is quite a high figure, as much as 8% of maternal deaths per year, they are due to abortions. In fact, this is the third leading cause of MMR. And nearly 2 out of 3 of the abortions that are performed in our country are deemed unsafe. Nearly half of the pregnancy-related deaths, they are in young women, that is, who are less than 20 years of age, 24 years of age. Now, according to WHO, when is abortion considered as safe? It will be safe only when it is performed by a trained person and by using an appropriate method. Even if the person is trained, but the method is wrong, it is not going to be safe. It is going to be less safe. And it is absolutely dangerous, or it is highly unsafe if a wrong person who is not trained in this and using wrong methods, they are carrying out abortion. So that might lead to morbidity and sometimes mortality also. Now, this is the amendment that we are going to talk about mainly. And we'll see one by one what changes are being made. Now, in the previous act, we required opinion of one provider for MTP up to 12 weeks. And up from 12 to 20 weeks, require 2 opinions, that is opinions of 2 RMPs that were required for 12 to 20 weeks of pregnancy. Now the new amendment allows that even up to 20 weeks of gestation, only one opinion or opinion of only one registered medical practitioner is enough. And when we are extending the period of abortion up to 24 weeks, now this is something that has been added, that is 4 weeks more, in which we can legally carry out abortion. For this 20 to 24 weeks, opinions of 2 RMPs are needed. Now, how it has helped? There will be increase in the number of facilities, especially in public sector like PSCs, which are eligible for service provision till 20 weeks. That is, so far, at many places, especially PSCs, only abortion up to 12 weeks was possible with the opinion of one person, one RMP. But now it has increased the provision up to 20 weeks. Only one opinion suffices. In previous act, MTP was permitted beyond 20 weeks only and only when it was immediately necessary to save the life of the pregnant woman. That is, if she suffered from such a condition which required termination of pregnancy to save her life, only then it was permitted. But in new amendment, the upper gestational limit has been increased to 20 to 24 weeks for special vulnerable categories of women. So there is a wide scope of this in this increased gestational age. And further enhancement for birth defects not compatible with life on medical board consensus. So because of this, there will be increase in the access for vulnerable women to safe and legal abortion services defined by Rules Committee, which includes violence victims, minors, among others. We'll see this in details, who are the vulnerable categories of women. Previously, the Act had provision for termination of such pregnancies only up to 20 weeks. Now this has been increased to 24 weeks. And whenever there is such a condition in which the termination was carried out up to 20 weeks to save the mother's life, now this upper gestation limit does not apply in cases of pregnancies with substantial fetal abnormalities diagnosed by medical board. So there was a lot of problem, that is, some of the diagnosis of anomalies, it was made around 20 weeks. By the time the patient could decide or she could gain access to the safe abortion services, she had already crossed 20 weeks. And then there was a lot of dilemma what to do. We had to go to the courts to allow us to carry out this MTP. So now because of this, there is 4 weeks increase in the gestational age, in which definitely this 4 weeks can allow without any problem, legally allowed up to 24 weeks. So it has caused increase in the access to safe and legal abortion services, who often seek service late beyond legal limit of termination of pregnancy, since with substantial fetal anomalies diagnosed late, thus reducing unsafe abortions and court cases. Previously, the condition of failure of contraceptive was applicable for only married women or her husband. Now, recently, it is going to be changed, that is, the age of marriage is going to be changed to from 18 to 21 years. So there are a lot of girls, young women, who are likely to indulge in sexual acts, and maybe even if they are using contraceptive method or the partner is using contraceptive method, they can become pregnant. So initially, these women, they were not considered as candidate for abortion on the grounds of failure of contraception. Now this has been changed. So now the condition of failure of contraceptive, it is extended for any woman or her partner. That is, of course, up to the legal limit. So this has increased the access to safe and legal abortion for any woman, irrespective of marriage age, especially with upcoming changes in the legal age that I have told you. It is an important advancement for increasing access to safe abortion. Now, this is another important way that is insertion of new clause for strengthening privacy of the women. The medical termination of pregnancy regulation 2003 with that amendment, previous amendment, mentioned that information should not be disclosed except under authority of law. Now this authority of law, it was quite vague. Now in this new amendment or new insertion, the name and other particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. So this is important sentence, authorized by any law for the time being in force. He is not a permanent or she is not a permanent authority, and only when they are authorized for that particular time being, then they can gain access to this information. So the potential outcome of this changes, new insertion in 2021 is, there is increase in privacy and confidentiality of abortion seekers, increased demand, but need to safeguard rights and dignity of women and provide respectful bias-free services, including counseling and contraception. So this is a welcome change, we can say. That is, the ground of failure of contraceptive has been extended to women and her partner also, and it is not necessary that that woman should be married. Now, rules under MTP Amendment 2021 defines special or vulnerable category of women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. This is a major breakthrough. The norms for RMP, whose opinion is required for termination of pregnancy at different gestational age, we are going to see this. Then the powers and functions of medical boards. Now, this medical board is newly added. It consists of obstetrician gynecologist, a pediatrician, and if necessary, radiologist. And that medical board can seek advice of some other person like pediatric surgeon or some other expert like psychiatrist, or whenever whatever consultation is needed from a specialist, that board can approach that person. Now, special category of women, this we'll see in detail. Special category of women eligible for MTP between 20 and 24 weeks. That is, this is newly increased gestational age. One is survivor of sexual assault, rape, or incest. Now, particularly, these are the women who are likely to report late, maybe out of fear, maybe for whatever reason is there, maybe she might be even minor and she may not think that she might be pregnant or a rape or incest victim. They might take some time to approach. Even their guardians or parents may not be aware of what has gone wrong, leave alone the medical fraternity. So it is likely that this women, they approach us quite late and they are given this now 4 weeks additional period. So even if they come late, they are definitely eligible to undergo MTP. Women with pregnancy in humanitarian settings. Now, for example, currently because of COVID disaster, that is, family might be thinking that they could raise their child, but now because of this changes in their socioeconomic status, they might have lost job, or one of the partner might have died because of this COVID pandemic. So such problems, these are the emergency situations which are declared by government, in which the couple or the woman might have taken some more time to decide what to do about her pregnancy, whether to continue it or terminate it. Similar now is the case with the ongoing war between Russia and Ukraine. So these are some special emergency situations in which this woman will be allowed this increased eligibility, or they are likely to be benefited because of increase in the gestational age for MTP. Now, change in the marital status during the ongoing pregnancy. Suppose the patient is unfortunately widowed, or she seeks divorce. That is, maybe at the beginning of pregnancy, everything was all right. And later on, this was noticed that she is widowed or she's getting divorce or applying for divorce. Then again, this period might have extended from beyond 20 weeks. Then women with physical disabilities, again, they might have sought delayed opinion. mentally ill women, including mental retardation. Then minors. This mentally ill women, minors, rape victims, all these are the category of women who are likely to seek medical advice late. So they are definitely going to be benefited with this amendment. Then fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. Now, as I've told you, sometimes the women themselves, they go for sonography a bit late. By the time the sonography appears, sonography report discloses some abnormality, they might be referred to some echocardiologist or some second opinion to confirm the abnormality. So by this time, it is likely that she has crossed 20 weeks of gestation. So because of this increase in the period of gestation for MTP, such category of women, in fact, for the last few years, we are having this problem, fetal malformation, maximally seen because of the stringent PCPNDT acts. Now people are fearing to carry out second trimester abortion. So it is possible that this woman, she might have approached some gynecologist before 20 weeks, but by the time finally some gynecologist is ready to carry out MTP, she might have already crossed 20 weeks of gestation. So this definitely has increased the possibility that patients now can seek MTP even up to 24 weeks. Now about the registered medical practitioner. Registered medical practitioner means practitioner recognized by MCI or now NMC who is an MBBS doctor. So this is the recognized RMP. Things are same, that is medical practitioner assisted who has assisted 25 cases of MTP, of which at least 5 have been carried out independently by her or him. Medical practitioner who has completed 6 months of residency in obstetrics and gynecology, or a practitioner who holds a postgraduate degree or diploma in OBGYN. Then medical practitioner who has experience of at least 1 year in practice of OBGYN. So these criteria are same, but now the difference is up to 20 weeks instead of 2 opinions, 1 opinion, that is opinion of 1 RMP suffices. And for 20 to 24 weeks of gestation, then opinions of 2 RMPs are required. And beyond 24 weeks, medical board are to be established. So far, they are not established, but that's definitely in coming few days, a few weeks, if not days, medical boards will be definitely established all over wherever this MTP facilities are available. So they can opine, and the women or the couple, they can seek MTP beyond even 24 weeks under special situations. Now this new norm for RMP is added now, and that is for medical method of abortion. And under this, an additional category of provider has been added. That is for termination of pregnancy up to 9 weeks with medical methods, that is with the use of Mifi and misoprostol. For this, the RMP should be having experience in the practice of OBGYN, at least at any hospital for 3 months, training with performance of minimum 10 cases, not necessarily now for 25 cases, but 10 cases of MTP by medical method of abortion under supervision of RMP in a hospital established or maintained or a training institute approved for this purpose by the government. That is a person or a RMP with such experience who is not having her or his own hospital, but having this experience that is imported, she or he can perform this medical or can prescribe medical method of abortion. And she should or he should display the certificate that they are having backup services from a recognized hospital where facilities for intervention like suction evacuation or whatever is needed is available. So now this new amendment, these norms have been added. So this is same repetition of whatever just now I've described. That is up to 9 weeks for medical abortions. Till 12 weeks, whatever was there, it is still there. And now this has been extended to 12 weeks to 20 weeks, only one opinion is required. That is the main addition in this or change in the norms. So now this people who are practicing in PSC or working in PSC, they can, without opinion of second RMP, they can go ahead with MTP even up to 20 weeks. That is a major difference. So more women can see, they don't have to go to higher centers to get opinion of second RMP. And from 20 to 24 weeks, definitely 2 opinions are required. Now coming to this medical board, the norms for RMP, whose opinion is required for termination of pregnancy at different gestational age, that we have already seen. But when the pregnancy has grown beyond 24 weeks, then who can decide this? Of course, the decision that the patient requires MTP, it can be taken by a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, or a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. So only these 2 categories of registered medical practitioners, they can opine that this patient requires MTP even if it has gone beyond 24 weeks. But most important thing is, now the opinion of medical board is required in this. For the termination procedure, when advised by the medical board, it is to be carried out with all safety precautions along with appropriate counseling and at approved place. So this medical board is something which is going to be established in all the district places. And this composition of medical board will be main gynecologist, a pediatrician, preferably a neonatologist, and a sonologist or radiologist. And the powers of this medical boards are to allow or deny, that is, it is up to them, this board, up to the board, whether to allow or deny termination of pregnancy beyond 24 weeks of gestational period. And they will be allowing this only after due consideration and ensuring that the procedure would be safe for the woman at that gestational age, and whether the malformation has, the fetal malformation has substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. So that is why not only a gynecologist, but even a neonatologist or pediatrician and a sonologist is included in this. And if the board deems it necessary that some other opinion also should be sought, as I've told you, a cardiologist's opinion, pediatric cardiologist's opinion regarding some cardiac abnormalities or cardiac problems, so that the baby would require some major surgery because during which it can succumb, or as such it may not survive. So opinion of a pediatric cardiologist can be sought. Similarly, opinion of a pediatric surgeon also can be sought by this board, and then they will give their opinion whether to allow MTP, and even they can decide this, that is, whoever has referred the patient to them, whether the hospital owner or the person who is going to perform MTP in her or his hospital, whether that is a safe place, or whether this patient should be referred to a higher center where facilities are much better and it is much safer for the woman to undergo termination of pregnancy beyond 24 weeks. So these are important amendments. And this medical board, I don't think it has been established anywhere so far, but it is expected to be established in all the district places. So the function of the medical board is to examine the woman and her reports who would approach for medical termination of pregnancy. This woman is not expected to directly approach the medical board. It is we, the person who is thinking that she requires termination of pregnancy, is going to refer this patient to this medical board. Then they will provide the opinion of medical board in Form D. There is a separate Form D now with regard to termination of pregnancy or rejection of request for termination within 3 days. That is, they have to take decision within 3 days of receiving the request for medical termination of pregnancy. Then they have to ensure that MTP procedure, whatever way the procedure is going to be carried out, is carried out with all safety precautions along with appropriate counseling within 5 days of receipt of request for MTP. So there is a time limit during which this board should decide time limit during which the pregnancy should be terminated from the time of request. Remember, FOXI has an important role to play in ensuring there are functional medical board in every state, as is stated in MTP Amendment 2021. So that was regarding the amendments in the MTP Act. I thank you for the patient listening. So let us make it safe and respectful, that is abortion. In fact, India is a country where abortion is legalized at the earliest quite long back. And even as compared to Western developed countries, so-called developed countries, India is much, much ahead of allowing abortions in a legal way. Thank you.
Thank you, Dr. Pushpa. Dr. Pushpa, there are some questions in the chat box.
Yes.
Would you like to answer them? Dr. Shalaka has asked, how about confidentiality? How to counsel patients regarding confidentiality, especially if she's unmarried? And then the second opinion is a second signature on Form C, or like if you can try to take those questions.
How about confidentiality? How to counsel women regarding confidentiality, especially if she is unmarried? In fact, the patient needs confidentiality. That is, even if she wants to disclose it to her family members or whoever she wants to display or disclose, I don't think it is our responsibility that she should not tell anyone else. It is for us, the confidentiality.
Dr. Pushpa, it is regarding, not disclosing the name of the person, it's already, you have talked about it, See, we cannot disclose the name of the person who is undergoing the abortion on any case sheet or anywhere, even in the OT register, nowhere else. No, we cannot write it. Only in the register, the abortion register, we can write the name, and there we will give a particular number, and then afterwards in each and every document that number itself will be written, and no name, no disclosures are to be there anywhere, not even in the OT register. I think everybody is following, and that is what we are talking about.
This is for quite long. That is this.
Everybody is following it, and that is what she's. So it is, again, we can reiterate that whatever we were following as far as confidentiality.
Shalaka is asking how. I think she meant something else. She is asking how to maintain confidentiality. That is what she is asking.
It's the same thing. What do you think, Dr. Basu?
Yeah, I think it's not. Yeah, somebody wants to say. Yes.
Yeah, it was my difficulty. I think there is something wrong. I am Dr. Shubhangi Mundra.
Yeah.
I wanted to know if she has to be terminated after 20 weeks and she has to go for the third opinion of two doctors. Then how can she be counseled for regarding confidentiality? And supposing can she be terminated just on the grounds that she is unmarried, she is more than 24 weeks? Can she be terminated just on this ground? And in that case, how can she appear in front of the medical board? Because then
this is not a ground for termination. Simply she is unmarried is not a ground for termination of pregnancy beyond 24 weeks.
Yeah.
Up to 24 weeks.
Yeah.
It is up to 24 weeks. Beyond 24 weeks, there are other grounds.
We need to tell her that I'll take opinion from two people. And then only I can touch you. That is what?
No. From 20 to 24 weeks, it is all right. But not beyond 24 weeks. And even for 20 to 24 weeks, third opinion is not required. Third opinion is not required.
Okay. After between 20 and 24 weeks.
So only those are the amendments, Dr. Shubhangi. Initially, previously from 12 weeks onwards to 20 weeks, 2 opinions were required. Now that is changed. Up to 20 weeks, only 1 opinion will suffice. 20 to 24 weeks, 2 opinions. 2 opinion means what? The second signature has to be there on the Form C. That is what we mean. That means 2 people have seen her and they ascertain, yes, the grounds for termination are there, and then that person signs there on the Form C.
Yeah, now I got it. That 12 to
Right.
20 weeks, only 1% signs.
Right.
Yeah. Thank you so much.
Thank you. We're moving on with the program. So I'll just share my screen. I'm the second speaker here, and the next 15 to 20 minutes will take you on this section of the program, which is of the module, which is on updates in technology. So what I'll be discussing now is something which most of you would be aware of, but I'll just run through the slides and the slide deck that we have. So over the next 15 to 20 minutes, we'll be running through existing guidelines which are already there on medical methods of abortion and surgical methods of abortion. We'll just highlight the pre-abortion assessment which is required and some advancements in the medical and surgical abortion. So whenever we're talking about abortion, you remember the orange books. These orange colored books come from WHO. The first one in 2012 was on safe abortion, which people who may be familiar with. And the one in 2018 was on medical management of abortion. In between, there have been others. And the last one is the health workers' role in providing safe abortion care and post-abortion contraception. These all are available on the WHO website, and it's a free download. Please be free to see it at your leisure and understand. Similarly, the WHO publications have been replicated nationally. WHO encourages countries to use their publications and have a national flavor to it. And that's what India has done. And the adoption of the WHO guidelines, this was one which was published, I don't remember the year, and this is the last one which has come up, the landscape assessment of availability and quality of medical abortions. All this can be downloaded free from the net. We have already heard about the change in the law, MTP Amendment Act. Dr. Pushpa took us through that and what the changes are. So that is something which is important. After this session is over, if you have filled the pre and the post-test questionnaire, you will be eligible to get all the information and the slides that we are showing you now. So you don't need to keep any of this. All of this will be yours for you to train other people in the course of time. So all this will be yours. And this is the slide deck which we are uniformly using for this training module and which you will be going on to train others. All guidelines have three key areas in the management of safety: this pre-abortion, abortion care, and then aftercare and follow-up. I think all of us do understand that when people come to you for an abortion, the first question which you obviously ask is that how sure are you whether you want to do an abortion or you want to continue your pregnancy? And that's where it starts. You possibly may give her a couple of days to think over it, because people may not think so much when they come to you. So detailed history taking, a physical and a pelvic examination in many cases, and we'll discuss that, laboratory and other investigations and decision-making, information on abortion procedures and counseling. So gestational age, we know that after 12 weeks, the uterus rises out of the pelvis. Then you can feel it per abdomen. Before that, it's of course in the pelvis, and with experience, you know how a 6-week, 8-week, 10-week, and 12-week uterus generally feels. But generally, you would have an idea by a bimanual pelvic examination about the size of the uterus. And WHO usually stresses to do a bimanual pelvic examination rather than depend on a sonography thing. In the private sector, we often do a sonography, and it's sometimes a good clinical practice guideline to have a sonography done in early pregnancy before a miscarriage, but we know it's not a mandatory requirement and it's not a necessity. But the times when you would need to do a sonography is when there is a wrong dates where you think that the uterus is feeling larger or smaller than what gestational age is there. Then there's marked obesity where you cannot really feel it properly. And there are other issues where you suspect an ectopic at the same time. And then there is multiple gestationals or something where you suspect it's larger than date. It's retroverted where you can't feel the size. Those are some cases where you would be asking for a sonography. Often we do it routinely, but that's not a recommendation. So pre-abortion investigations, what are things need to be done? So what needs to be done, of course, is a pregnancy test to confirm that she's pregnant if you haven't done that before. A hemoglobin would be something very basic. Blood grouping would be very basic. And then STI screening is recommended in case she doesn't have screening, but that again is not something which we usually do. But STI screening is something very commonly done in a lot of other countries. But in our system, we usually like to treat for STIs more than screen for them. And HIV testing counseling, again, not a necessity, not done here, but that's something which is mentioned. Other lab tests, no. Ultrasound, as you see in the highlighted portion in the lower part of the slide, is which is not necessary unless to diagnose a pregnancy, not certain or suspecting an ectopic or a missed abortion. Pre-abortion counseling. So the first thing I said is the thoughts about terminating the pregnancy, really finding out why does she really want to terminate it? Is it is somebody forcing her, or why is this situation come? Whether she can consider at all to continue it. Reason for terminating, whether it falls in your MTP laws, whether we can put a reason for her and why exactly she is going through this. So in the form C, we have to find out what is the reason for termination, failure of contraception, something else, and etc. So we try to inform her that early abortion is safe, important to have a trained provider and the methods of abortion. That is one point of time we'll bring it up, that whether she's eligible for medical abortion, also depending on the gestational age that she presents to you with. Then the risks and warning of abortion, when she should return, the red flag signs, when she should return to the clinic in case something goes wrong, what can go wrong, if she doesn't have any bleeding, she needs to report, etc. And then when she used to need contraception, and when can she resume her sexual intercourse and other activities. So it's important to get, so irrespective of whether we are having a medical or a surgical abortion, you need to fill the forms. Form C, Form 1 has to be filled, and that is something which is a necessity, and you need to keep them. So clinical management of abortion, this is one of the wheels of GOI. Medical is now recommended until 9 weeks, and after 9 weeks, it goes generally to a surgical. So medical or surgical before 9 weeks, and generally surgical after that. But tablet mifepristone and misoprostol, I think we are all familiar with how it works. Mifepristone is the antiprogestogen which we give before we give the misoprostol or PGE1 analog, and which causes cervical softening, contractions, and ultimately expulsion of the products. So generally we characteristically do it by day 1 and day 3. You have a 36 to 48 hour gap between the mifepristone and the misoprostol. If she's Rh negative, you want to give anti-D, you would like to give it initially, but sometimes 50 may be difficult to find, then you give 150, 100, or even 300, depending on what you are available, what is available. And mifepristone administration, we'll come more towards it, but a lot of us would like to give analgesics and antiemetics along with it, because we know from experience that a lot of people have a chance of vomiting out the medicine. So antiemetics 1 hour before is a good practice, which a lot of us normally practice. And also offer contraception, because a lot of times we understand that the woman coming to you in the clinic may be the only time she's coming. So even though it may sometimes think that you are bombarding her with information and giving her a lot of information, but sometimes it may be important because that is the only time she'll come to you and she'll listen to you. So ideally it's day 1, day 3, and day 15. There were 3 visits which were characteristically lined up by the government of India, but generally it may be all combined into 1 or 2. But the most important is that we must make sure that everything is covered and the woman has understood it. Coming to the administration of the misoprostol tablets, well, there is oral, there is buccal, there's sublingual and vaginal, and each one has different pharmacokinetics, like their peak of action and the duration of action, it differs. But the orals one, the swallowed is what generally a lot of people do, but buccal and sublingual generally work best, where you have to keep them in the mouth for 30 minutes. In buccal, you keep it just next to your cheek, and in sublingual under the tongue. And this is where you keep it for 30 minutes and ask to swallow. Some people will ask you, is this a dissolving tablet? And the very specific answer is no, it is not a mouth dissolving tablet. It tastes awful, but at the same time, that's the best way in which it acts. And when you say that it works better this way, you swallow it after 30 minutes, then that's fine. Sometimes if you can keep it for 15 minutes, that's also good. But again, the side effects are more fever and chills, usually not with the dose which we use in abortion. When you use repeated doses, we see more of this fever, chills, and diarrhea, not usually after the one which we use for a medical abortion. But of course, the reactions may differ from person to person. And if you're using it vaginally, best to use it up in the fornices and to lie down for 30 minutes, the same instruction we used to give when we give, or when we still give misoprostol for induction of labor. So this is the routes which we mentioned, and the WHO makes it quite simple. In the latest guideline of WHO, it's less than 12 and more than 12. So you don't need to break it up again. And mifepristone, they changed from hours to days. So 1 to 2 days between mifepristone and misoprostol. So anything between 24 to 48 hours, where you give 200 milligrams once and 800, that is 4 tablets, buccal or per vaginal or sublingual. So it's preferable any of the 3 routes other than oral. So either you give it, ask them to put it vaginally. Sometimes people may be a little uncomfortable. Buccal and sublingual work best. We have a 1+4 kit, and that suits it right, that we use 1 and 4 altogether. In countries where mifepristone is not available or has not been licensed, there misoprostol alone regimes are looked on, and this is what they use for mifepristone alone. Of course, we know it's not as effective as using both together, but sometimes this is the best which some countries can offer. So vaginal bleeding for 2 weeks is generally normal. There was once upon a time when we used to do sonographies very early after medical abortion. We used to do it in 5 days, 7 days, and 10 days. And then you did a lot of evacuation for retained products, which often is not necessary, because in 15 days, usually most of it clears on its own. But if it persists and intermittent bleeding, then of course we need to look into it. So in India, as we understand, a lot of the healthcare is opportunistic. So when a woman comes for an abortion, she also has a checkup that whether she has STIs, whether she is having abuse, whether she has psychological issues which need to be addressed, or there are other iron deficiency, anemia, and other emotional support. So you need several other issues may also be looked into, some related to the abortion process, some exclusive from it, but at the same time, those are things which could give an idea, could again, as a part of the wholesome care, respectful abortion care, we should need to let the woman as a whole. She's come for a miscarriage, of course, but that's not the only thing. She's got more to her. She's got may plan a pregnancy sometime later in life, in her reproductive life, which we need to handhold her and make sure that she gets it all right the next time. So follow-up care, routine follow-up care is not necessary following an uncomplicated medical abortion. But as we mentioned, if that visit is the only visit, we must red flag the signs of where there are some things which may go wrong, complications, very heavy bleeding. We'll come to some of it very soon, and when she needs to report to the clinic or come back. A follow-up visit of 7 to 14 days often is useful, because at that time a woman is too anxious and stressed out, but later she may relax and take more information on contraceptive counseling and other addressing. So women's recovery asks for signs, symptoms of ongoing pregnancy, medical records. This is something, and the summary here is the first day visit, you do what is required and give the mifepristone, and then ask her to come back after 2 days. And then there is 3% of women may expel completely after mifepristone. And that is something also which you tell them, but at the same time, tell them to complete the course. They don't stick with mifepristone alone. So even nevertheless, they complete the course. Sometimes, as we said, antiemetics 1 hour before misoprostol may be a good idea, so that her chances of vomiting it out are less. And then you have ibuprofen 400 as an analgesic, which you give her. Some people that may save you a couple of phone calls, which people will give you when they are expelling products at home. So mean period of bleeding is 8 to 13 days. Possible side effects, I think most of us know, nausea, vomiting, and it's mostly temporary. Excessive bleeding has to be defined. We need to understand that. Pain, abdomen, initially unbearable for a few hours, but then most people settle at home There hardly we needed any admission after a medical method of abortion during the process of abortion. But that needs a little bit of counseling between and a little bit of telling them what to expect. So 75% women abort within 4 to 6 hours of misoprostol administration. So she would like to take off from her office work on that particular day. Day 15, visit pelvic examination to ensure completion of abortion. That is what WHO recommends. You don't need to have a sonography. Normally, we don't always routinely do a sonography after a medical abortion. We assume it's complete unless there is intermittent and prolonged bleeding where you would need a sonography to see for RPOC, but otherwise it's not usually required. Side effects and complications, this is what we were mentioning. So pain, we must try to explain to her pain is integral part of medical abortion. How much of pain she may ask you, and then you can say it's something maybe double of what she normally gets during her worst period, and that time so she can correlate to some of it, and then you can support her with painkillers just at the time she has the problem. And it's usually, again, as the pain with the nausea and the diarrhea self-remitting, you don't need to give her any treatment for that. If it's a failed MMA, you have an option of repeating medicines, but most people would like to go for a vacuum aspiration for completing. And how would you know it's incomplete? Again, you observe the os will be open, there'll be passage of clots, intermittent heavy bleeding, and of course, a sonographic confirmation of retained products of conception. Options of repeat misoprostol is still there. There are people who have had variable amounts of success, but again, you give her the options and then she decides. But ultimately, a surgical recourse would be prudent often. Excessive bleeding PV would be defined as soaking of 2 pads in an hour for 2 consecutive hours. If she feels dizzy, if she feels giddy, if your hemoglobin initially was 8 to 10, then there's questions there about whether to have medical method of abortion, especially for advanced gestational ages. You may push her into more anemia and feeling more sick. And then if it decreases with time, you can keep a watch on her. But if it doesn't decrease, then definitely you need to possibly admit her or keep her under supervision and do the required and necessary what needs to be done. So as we said, for MMA, nothing different from surgical abortion. Form C, Form 1, 2, 3 have to be filled as is normally required. The methods of first trimester, let's move towards the surgical part. The medical part we have covered. Vacuum aspiration is a recommended technology, and it has been something with which IPAS, the organization, the last 2 decades and more, have been propagating manual vacuum aspiration. And also you have an option of electronic vacuum aspiration, which is the safest method and must be routinely replaced by the curette. The curette should not be on the instrument table. Unfortunately, this still finds a place, but at the same time, the same job can be done much better by an MVA. And so this is the handheld aspirator used to generate a vacuum. It can be used in different settings, and the cannulas are numbered according to the weeks for the easiest thing. This is the electronic vacuum aspiration, which we are used to in our OTs. And this is something before cervical preparation is something I think very standard. A lot of people do it and most people do it. How do they do it? That varies. Some people use 200, some people use 400, but generally 2 to 3 hours prior to the procedure, 400 works wonderfully. A lot of people use it sublingually, some vaginally, but this works wonderfully when a person gets admitted and waiting for a daycare, and then it leads to easy dilatation. Pain management for vacuum aspiration, usually whether you need anesthesia, well, some anesthesia, of course, is important. Local would be the best to start with. If that doesn't work, then of course you need to have the small TIVA, the total intravenous anesthesia. Again, not always required, but sometimes there's very anxious patients who may require it. But the important thing is to keep her comfortable. If your patient is cooperative and you can manage with a paracervical block, that's good. But if your patient is non-cooperative and you need to give her more than vocal tonic, in that case, possibly giving her a small general anesthesia would be fine, of course, without a tube, but some IV for keeping her quiet for 10 to 15 minutes. So cervical dilatation, uterine cramping, there are different pharmacological pain relief medication, which we need to provide to her, again, as a part of respectful abortion care. Do not think that ye to chalta hai, that she should be able to withstand this amount of pain. That's up to her, and that's her. Each woman's pain thresholds are different. It is up to us to find out what she can manage and what we can do for her. Steps of MVA treatment, of MVA procedure. If you just to revise that, close the valve buttons, create the vacuum, and then clean the cervix, and then administer the paracervical block, insert the cannula, and then suck out the containers and rotate it, release the vacuum valve in the thing, and then check the products, and then look for the foam. Concurrent procedures, yes, contraception and instrument processing at the end. The post procedure, yes, she can leave, make sure that all the documents are signed, and she has the phone numbers in case there is an emergency where she can contact. So after care, there can be incomplete abortion, infection, ongoing pregnancy, several issues can happen. But as long as you've explained to her, you have put it to her, then you are at least you're safe medically also, that these things have been explained. These are known complications. Anything can happen to anybody. Chances are less, but at the same time, it is something which has been explained to her. So India has made historic progress in improving access to safe abortion. I don't know what percentage of MMR is still abortion related. The last figures which came out recently, where it's come down to 103, I'm not sure whether they have the breakup there, but it was from 13, it's come down to 8 over the last 20 years. And a lot of it is attributed to the medical methods of abortion, which cannot be, at the worst situation, more harmful than the surgical. Not much has changed. The technological updates, what you've heard is more or less most of things of what you already know. Just some about the medication, some closes here and there, ensuring safety, quality. And as we said, that this is the program on respectful abortion care services, and that's what we want. So it's important to make sure that before you check out and log out in the end, you will get a box where you would be necessary to give your post-test and feedback. Only then will you be getting your certificates. A lot of people in a hurry try to leave very early, and then they have a problem, and then that's from the back end, Ajay will be trying to get you these things sorted out. Thank you very much. It's been a pleasure talking here. So there are a few questions which I'll address as we run through this. In missed abortion or blighted ovum, should it be filled? So I think it's very clear that there are 4 situations where you don't need to fill up. One is a molar pregnancy, and one is an incomplete abortion. Those are ones you do not need to fill up MTP forms. You need to fill up your OT register. So your OT register is something where any procedure would be done, would be recorded. So that would be recorded, but you don't need to fill up the MTP forms. And the next thing was when no contraceptive is used and patient does not want pregnancy, what indication should be written? Yes, that's a very good question. That's so many times it happens now. So failure of contraception, I think abstinence is not a contraception. Then you have to use the other criteria which is there. Grave mental, physical injury, whatever you want to say. The other things, I think those are things which have to be used. Contraception is there. Missed abortion, you can take, okay, I think this Dr. Pushpa's answered. I think Dr. Pushpa's answered. Yeah, other indications. Do we have to follow up, register after medical abortion? Well, if you're doing a study, it's a nice idea to follow up. Also, it's a nice idea to follow up what's exactly happening. Again, respectful abortion care means not just fill it, shut it, forget it. You have to follow up the woman and make sure that she's had enough of hand holding, that she's continuing well with the contraception you've provided her, or she's quite happy with the services provided, that things are. So some follow-up after a medical abortion is ideal, not always possible and practical, but it's something which is a good idea if you can just say that, yes, she's doing fine. Is anesthetic necessary? IV diazepam? Yes, some people do use it. It's a little dangerous, some anesthetists say, but that is some of the things. 200 misoprostol given 10 to 15 minutes prior. Dr. Pushpa was saying 10 to 15 minutes prior, orally to 10 to 15 minutes. I don't know, Dr. Pushpa. For me personally, I think 1 hour would be a good time. But again, sometimes like this would be like, even if she comes for a daycare surgery, she would be having a few, at least an hour time before you usually wheel her into the OT. So she'll be getting her things ready. Even at that time, if we put in a sublingual misoprostol an hour and before, it usually works well to soften up the surgery.
The reason why we can give it just 10 minutes prior is stomach is the greatest cavity or largest cavity with with mucosal absorption.
Yeah,
and
but
it is rapidly
yeah.
acts, and the peak action by oral route is 8 to 10 minutes.
Yeah, actually, Doctor, like the pharmacokinetics, Dr. Pushpa, are different from each route. I think that's another discussion, another time, like sublingual, buccal, like what time it takes for the drug to reach its peak, till how long it stays in the system. That's another discussion, another time. But I think any route we give, it does work, and it may be a good idea to routinely use it before cervical priming. Thank you very much. I move on. I think Dr. Surekha is waiting. She will be taking the next section forward, and then we will be carrying on. Thank you very much.
Thank you, Dr. Basu. That was wonderful. When we talk of the next topic, it is on WHO Saver Kit. And before I move on to the actual topic, I would like to take you through one video which we are supposed to go through when we are talking of the WHO Saver Kit. This is called as the Guide to the WHO Saver Kit. I'll take you to the guide.
No woman should die due to an unsafe abortion, and when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO.
Is it not shared?
No, it was playing. You could hear audio, but we're not seeing the video.
Okay. Let me stop it.
Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Saver is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So that was about a small description or introduction of Saver. Now we are going to go to the actual Saver module or the presentation which has been provided from the FOXI WHO initiative of respectful abortion care. Now this is the what exactly is Saver. That is for the first thing we need to understand. Okay, so I think we have gone to the last slide. I'll stop share. Just give me a minute. So this is the module 3, as you can see here. It's about safe abortion. Okay, so SAVER means what? The SAVER is an acronym actually. It means Safe Abortion Values, Evidence, Rights, and Respect. So this is a SAVER toolkit which WHO has provided for respectful abortion care, that is RAC. Now, what is the aim of this module is actually the affective domain. When we are talking of, knowledge is cognition, when you're talking of the tools, when you're talking of skills, which is the psychomotor domain, which is addressed. But when we are talking of respectful care, it is also the affective domain, which is addressed. So we are talking here of respectful abortion care. What are the WHO standards for that? And we're also going to highlight some norms and stigma which affect the abortion services. And we're also going to guide you towards this WHO SAVER resources or the SAVER toolkit, which is available on the WHO website for respectful abortion care. Now the momentum has been created, the law has changed actually. And we all know the law changed on 25th of March 2021, and after around the 6 months of deliberations, the rules were changed on 24th of September 2021. Now, however, we do know that the dissemination and the implementation of the law does need a lot of support, and especially from the OB-GYN provider who is supposed to implement the law as far as the rules have been provided in the law. Now, Foxy is the largest provider base for abortion care. We all know that. And that's why this respectful abortion care module has been brought about in association with WHO. And this is an online training. It is possible to give this training because of COVID and the virtual platform now being accessible to all of us. So respectful abortion care can now reach all the providers. As Dr. Basab has said, the medical methods of abortion uptake has increased to provide early and safe abortion. However, when we are providing these medical methods, it is very, very important that we ensure as practitioners that we do not have any conflict with the PCPNDT law, and we follow all the rules as far as the MTP law is concerned and the PCPNDT law is concerned. So both these rules we have to follow correctly so that we do not get into any trouble. Now, apart from that, we have to remember that the patient's safety is important when we are talking of abortion till 24 weeks. We need to be very careful of which method we are adopting. Are we having the skill? Is the institution is having the infrastructure, not only for the abortion, but also for dealing with any complication. And so safety is important, respect is important, and the quality of care which is provided to this lady also matters more than ever. And thus, as OB/GYN practitioner, as Foxians, we have a big role to play. Now, what is respectful abortion care? Respectful abortion care, or RAC, has been derived from another term which is called as respectful maternity care, or RMC. And again, both of them have been recommended by WHO. Now, when we say respectful abortion care, we are talking of safety, we are talking of dignity, we are talking of confidentiality, and again, freedom from harm and mistreatment. And again, we are talking of informed choice. So the lady should be knowing what all choices available for her, what are the pros and cons of the choice, and then she can take an informed decision what kind of care she wants. And of course, support during and after all types of abortion. Even if she does carries out the abortion multiple times, we cannot be judgmental, and we have to provide support at all times and at all events of abortion which has happened to her. In simpler terms, respectful care means that as a provider, you as a provider or a patient should treat as well as be treated with dignity, empathy, and compassion, regardless of, the class, the race, ethnicity, gender, socioeconomic status. This is all very important. If you're talking of the abortion care being received in large public health settings, there is a possibility that the woman is mistreated, and that is why these all terms are so very important when we are talking of socioeconomic status, reproductive history. Sometimes it happens that she has undergone a MT for a number of times, and that is where the provider becomes judgmental, and may mistreat the person, may verbally abuse the person undergoing the abortion. Thus, if she has undergone number of miscarriages or number of abortions, we are no one to judge her, and that is where when we talk about respectful care. So if we also have to, counsel the patient, we also have to assure the lady that if she feels that something misrespect or disrespect is happening to her, then it is her right to speak up. As a health professional, it is your duty to listen to her and support her. Thus, communication is the key to a respectful abortion care, and providing good quality of care is very important when we are talking of respectful abortion care. Now, let us look at certain norms and certain stigma. When we say norms, we are talking of certain rules which are existing in the society, which a person or a lady or even a man is supposed to follow. These are unwritten rules. Actually, when we say something is normative, means it is existing in the society. There is no written rule, but you're supposed to, follow it. Like not having a pregnancy prior to marriage is a norm, But so that is where, certain stigma and certain norms perpetuate disrespect, not only in the community, but also through the healthcare provider. So because of these existing norms, maybe the person who is undergoing the abortion, the lady, has to suffer certain amount of abuse and disrespect. So these are the categories of abuse. Like it could be physical abuse, though the physical abuse and slapping is more evident, commonly seen in public healthcare setting, large volume settings wherein, in maternity, like in delivery suits. However, it has also been known to occur during abortions. And if not actual slapping, then intimidating the person physically also has been seen. So it is a right of the woman to be to have freedom from all these kinds of ill treatment, and WHO explicitly, counsels the healthcare provider to not adopt any of these intimidating actions. And of course, verbal abuse, when we are saying verbal abuse, it also includes consented care. Like in maternity care, given an episiotomy without taking a consent, applying of forceps without taking a consent, such kind of procedures also occur in abortion settings also. So doing any procedure or using any technology or tool without taking a consent in abortion is also called as verbal abuse, apart from shouting and screaming, which none of us should ever adopt. Then, of course, in case of abuse of power or taking advantage of a very young or vulnerable lady, sexual abuse, of course, it has to be totally, condemned. These all sort of abuse and disrespect has to be condemned. So apart from that, a right of the woman is to seek information, protection under the MTP Act, under the POCSO Act, the consent. If she wants to refuse something, then that is her choice. If she prefers not to tell at home, not to tell even her husband, that is her choice, and that is where we as providers have to support her. So If these standards, these professional standards are not met, if there is poor rapport between the woman and the provider, if the health system conditions, the infrastructure, there are constraints, the privacy is not maintained, all these things, if they are not properly taken care of, then we are not, attaining to the respectful abortion care which WHO has recommending. So the right of the woman is timely health care and highest attainable level of care. So the quality also has to be good. She has to have her choice, that is liberty, autonomy, of procedure, whether she wants to undergo or not, whether she wants to tell at home or not, whether she wants to use certain contraceptive or not. All this autonomy of decisions the person can the lady is supposed to have. So self-determination and freedom from coercion. Freedom from coercion meaning that if suppose she's a widow and she's having a 20 weeks of gestation, she has come to you for termination, and maybe some provider wants to counsel her that please continue the pregnancy, why do you want to terminate it? So such kind of coercion, freedom from such kind of coercion is the right of the woman. She is having a right of liberty of her own decisions. That is what respectful abortion care is. So domains are free from harm and mistreatment, confidentiality and privacy, dignity, respecting the woman's choice as far as the place is concerned, the method is concerned, contraception is concerned, effective communication. So there has to be the provider has to have certain soft skill, informed consent about the information she is seeking, assess to support the pre-abortion and the post-abortion support, quality of the physical environment and resourceable, equitable abortion care means even if she is of a rural background and low socioeconomic status, she needs to have the same quality of care which an urban woman with affluent class will receive. So competent and motivated provider is another important concept or domain of respectful care and provision of contraceptive advice, commodity security and continuity of care, as Dr. Basav was talking about, even after the abortion, even if a medical abortion has happened, receiving a follow-up care also is one of the domains of respectful abortion care. Now, apart from that, you have to remember that there are certain changes in the law. The law has become more liberal, and that will tell you the liberal law actually talks of amendments where up to 20 weeks only one provider. So thus, if there is one provider, that means there is more responsibility to that provider to give skilled care for counseling, contraception, referral, complication readiness, and dealing with complications. So only the one provider is the one who has responsibility up to 20 weeks. And up to from 20 to 24 weeks, again, special cases needs sensitivity. You cannot be judgmental as far as rape, incest, or such other provisions which are there in the law. You have to be very sensitive. You have to give timely services so that the law is implemented correctly. And we all know, and it has been imperative to prioritize confidentiality as far as abortion services are concerned, and we need to be mindful of certain socio-cultural norms also. Like if it's an unmarried girl who has come to you, you have to be very sensitive so that you can provide her respectful care. So there are certain guides available to this. There is a video available on how to avoid stigmatizing language. I will play that video after the presentation is over. And this is the Saver Cool Kit, which is available on the WHO website. I will be taking you to that website also. And that Saver Kit actually has these 4 modules. One is Engage, another is Inform, then Explore, and there are certain games. These are the 2 games which you can which you can play on the website. One of the game is the Cross the Line, and another game is Personal Compass. And through this game, you are able to explore your own views regarding gender, sexuality, preventing unwanted pregnancy, safe abortion, and other sexual and reproductive rights. So these are the two self-paced games which you can play by yourself on the website. I will just take you to that website after this is over. And the fourth module is Equip. All these 4 modules are available under the WHO Saver Kit in the website. Now, we all know from 1970s, there was the abortions were unsafe. India in 1972 onwards, we do have our MTP law amendments came in 2000. The abortion became safe, but now in 2020, we are not only talking of safe abortion, but we are talking of respectful abortion, with that effective domain coming in very, very strongly. So these are certain recap questions. According to WHO, restricting access reduces the number of unsafe abortion. Is that true or false? You can write in the chat box. Is it true? Restricting access reduces the number of unsafe abortion. That is not true. Actually, it is false, because if you restrict access, then the unsafe abortion are going to increase. So you have to provide safe access, and that will reduce the unsafe abortions. So what is safe abortion? Safe abortion meaning by appropriate method and appropriately trained person. So both criteria have to be fulfilled when we say it is a safe abortion. Now, this is another question. A 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. You are the provider. It is, as a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? What do we say? You can write in the chat box. So the answer is no. You're not supposed to be judgmental. You're not supposed to tell her to continue the pregnancy. She has taken the decision to terminate the pregnancy, and your job is to support her, and your job is not to force her to tell her to continue the pregnancy. So again, these are only reiterating, we are only repeating when we talk of these norms or recommendations. So under the new amendments, up to 20 weeks, 1 RMP, 20 to 24 weeks, 2 RMPs, and beyond that, if there are birth defects, there is no gestational age limit, and the person can go, the health seeker can go to a medical court. So let us make abortion safe and respectful. Samarth Bharat, Sampurna Bharat means safe abortion made available respectfully through the health system. So just I'm going to take you to that website. I'll stop share first. And I do want to take you to the website if it is possible. No, I don't know. This is the module. Downloads, Google. So this website is available here, and the toolkit is available. Just wanted to show you that website in case you want to go and play the 2 games which I was talking about. But I don't know, it's not coming here. Okay, so this is the game. So this is the whosavertoolkit.com, on which all this is available, and you can go and train yourself on the gender sensitivity as far as respectful abortion care is concerned. Just let me go to the site. Okay, are you able to see this?
Yes, we can see the form.
Rashmi?
Yes, we can see the form now.
Yeah, I know. This is the WHO toolkit, cross the line. Okay. However, I'm not able to show you the exact site because of probably the network issues are there. Okay. So this actually talking of WHO Saver Toolkit, it is a website on which you can go and the 4 modules can be assessed and you can have access to the 2 games which they are talking of so that you can train yourself towards gender sensitivity. Thank you very much.
Thank you, madam.
Thank you, Dr. Surekha Kaide, madam. It was wonderful listening to you. And I request respected Dr. Shobha Gudi, madam, to present her talk.
Yeah, thank you so much,
Respected Shobha
Rashmi.
Gudi, madam, Chairperson of Family Welfare Committee, Foxy. Welcome, ma'am.
Thank you, Rashmi. Thank you. Indeed, it is a privilege to be present on this dais, and my immense thanks and gratitude to Foxy, Dr. Shanta Kumari, the entire team. Am I audible? Am I audible?
And the volume is low.
Okay. Now am I audible?
Yes, ma'am. Yes.
It is okay.
Yes, ma'am. Yes.
Yeah. So thank you so much to Dr. Shanta Kumari, our beloved president, and the entire team, and also to the societies who have hosted today, the Amravati, Pusat, and Sangli, and also one more is
Chandrapur and Devli Sangli.
Devli Sangli. How can I forget Chandrapur? I still remember the wonderful public forum I did from the committee there. So without more ado, I shall share my screen because this is last but not the least. I think everybody understands today the importance of post-abortal contraception and the role of counseling. I think I was going through the list of participants and I could see that most of them are accomplished gynecologists. And it is so very good today that that abortion has been propagated as a service and not just as a procedure for this with this particular module. It is an entire service, and it is the whole purpose of this service is to see that the woman, as far as possible, does not have to decide to terminate another unwanted pregnancy. Well, that is how I would see it, because she needs to be given every instrument, every advocacy, every method of contraception possible, and every counseling against becoming pregnant with an unwanted pregnancy as far as possible. She should not have to decide to terminate her own child another time without being judgmental, as has been told so many times by the previous speakers. So this is module 3B of pre-post-abortion FP counseling, and this is about leveraging technology for referrals and online consultations. And all the consultants, I think, who have joined a decade or two younger than me, they are much more techno-savvy than I have been. And I think leveraging technology is the call of the day, and it will benefit a woman seeking abortion immensely if we learn how to do it. So what is counseling? It is a structured interaction. It is a structured interaction. It is never a one-way, one-way communication. It is always interactive, and it is in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. So it is never a communication of a didactic, instruction to follow a contraception, or even an instruction for following the technique of abortion. It is a dialogue. It is a two-way communication, and the woman has the right and has the atmosphere to completely be participative. So integral part of comprehensive abortion services, counseling is, of course, it is as important as the procedure. I cannot emphasize it more. The woman may need help in decision making. Always remember, she may be asking for for your help to decide also. She may not always come with a decision already made, and it will be our duty to counsel her in such a way that whatever is in her mind, she is able to see the pros and cons of that decision and makes the decision herself. Whenever needed, the spouse also should be counseled. Well, most often it is needed because the spouse has to be participatory. Male participation in contraception, family planning, and abortion care should be propagated to the hilt by Foxians, and therefore the spouse also should be counseled as far as possible. This is very critical. Help the woman to decide about termination, help the woman to choose the method, ensure delivery of complete information about the procedure. That is what we have to ensure, and help the woman to adopt a contraceptive method. So you can see that it is an entire service, and it is a service where when you may even require a team, you may not be able to do everything yourself, and it is not, it is not impossible to have a trained counselor in your obstetric unit who will help, who will aid in the method counseling or even in the general counseling for this. But of course, our skill is mandatory. The pre-procedure counseling ensure privacy and confidentiality. That is what a woman looks for. Non-judgmental, be extremely sensitive about it because she has made a very, very important decision, and she needs to be supported and not judged, and she should not be challenged morally or ethically about it. Establish a rapport with her, become her friend, use very, very simple language. That is very important. And in her own native tongue. Do not use English words too many if she is not familiar with the language. You allow the woman to clear her doubts. That is very important. Even if she is not coming out with doubts, it is important to place one or two questions. Are you wanting to know anything more? Do you want to ask any questions? And I think that lead should be taken by us. If she has made up her mind for termination, then assess her for the procedure. So that is important, to do a thorough assessment. Quick return of fertility. When we talk about peri-abortion family planning counseling, women need to know that post-abortion, there's a quick return of fertility. And this is important because many women will be laboring under the myth that they cannot fall pregnant again very soon. They need to know that ovulation can return as early as 3 to 4 weeks following a first trimester termination even, and similarly for second trimester, not later than a month. The opportune time for contraceptive acceptance is now because she has come with an unintended pregnancy. She is at a vulnerable stage in her life, and she will be able to listen to your advice about preventing it from happening again. Minimum 6 months gap before next pregnancy, that is healthy spacing advocated by the government of India as the WHO as well, that a minimum spacing of 6 months gap from an abortion is very mandatory. The health benefits and the better future pregnancy outcomes are huge incentives to offer her, to tell her that, see, this is what is important for your future and your family's well-being as well as your health. 90% of abortion-related mortality can be prevented by ensuring contraception. So I think each one of you should take this message, foremost in your mind. One sentence, that family planning is life-saving. It is life-saving, both in terms of the maternal mortality that it averts, the maternal morbidity that it avoids, and also in terms of the reproductive wastage which happens if the woman falls pregnant again and again with unintended pregnancy and seeks abortion. Please do not remember, please do remember that that is reproductive wastage as well. So when to start? When to start? Well, you can start ASAP, very first visit. The very first time she comes and sits in front of you, after having told her about the abortion, it is important to counsel her. The one exception may be a grief management. That is when possibly what is meant here is when she has suffered a miscarriage on her own. Kindly mute. Kindly mute. Yeah. Kindly mute. Okay. What should we tell her? I have already spoken about return to fertility. It can be as early as 10 days and definitely as within 4 weeks. Help her with the choices. that is important, then that means that you have to offer her the basket of choice. Once she has chosen a method, the method specific counseling should fall in place. And whenever there is a high risk behavior, whenever a woman has higher risk of contracting an STI or even AIDS, it's important to do the proper counseling, perhaps a dual method of contraception, like a barrier in addition to the ongoing method, is necessary. If the woman is not willing for any method, please do not refuse the MTP. Go forward with the abortion procedure. Try and counsel her after the procedure. If she's still not willing, call her for follow-up in a week's time and counsel. If I may put in a one word here, that if for those couples, and here this is the opportune time to bring in the spouse or the partner or the boyfriend, whoever, and it is important to counsel him as well. This is an opportune time to bring in the concept of emergency contraception, to educate them. Okay, you are against a routine method, an ongoing method, but at least be aware about emergency contraception and also about barrier method of contraception, which feels like it is non-medicinal for them and they might accept it. Assessing suitability for post-abortive contraception is important. And you can see all the boxes are ticked there. What are the boxes to be ticked? The process should be complete. Uterine cavity should be empty. There should be no infection. There should not have been any injury to genital organs. And the chances of fresh pregnancy are ruled out. Now, though these boxes apply mainly to the insertion of an intrauterine device, but it is important to rule this out and check all the boxes in every method of contraception that we are offering. The critical role of post-procedure counseling cannot be, overemphasized. Ensure that the woman has understood the precautions and care needed during the post-abortion period. About opportunity to counsel contraception in case not previously accepted, please try again. Try and try again. Reinforce the need for continuing the use of contraceptive method which was chosen. Reinforce the need. Here is another caveat. If the pregnancy has resulted from failure of a prior method, but the woman still prefers to use that method, please do not discourage. It is so much possible that the method was not used perfectly but typically, and therefore the failure has happened. So give her counseling about the perfect use of the method and let her continue if that is what she wants. Continue to assure privacy and confidentiality, reassure her in case of any problem, and repeat the information about post-procedure care and danger signs. That is important. If at all there has been a problem in the abortion technique or in the procedure, then we need to tell her about it, and we need to look out for complications, which has already been dealt with Dr. Basser. Now, post-abortion counseling, already opted contraception, it's wonderful. Appreciate her for it. Saying, good things is going to go a long way. Immediately, what is required, if she has chosen a device, insert it. If she has chosen an injection, provide it. Ongoing will be the oral pills. Follow-up protocol should be written and given. Continuity, like reproductive intuition, you must discuss it now, and you must talk to her about her future reproductive plans if necessary, and necessary cards can be dispersed at this time as per the institutional protocols. Suppose she is undecided, she doesn't know, she doesn't want about the family planning method, then allay her anxiety, tell her that all about contraceptive methods are well researched and they are very, very safe, and there any small risk involved or side effect involved is minuscule as compared to the risk of repeated abortion. Importance of immediate adoption and the chosen method should be told to her. Extend the period of adoption of method. Couple counseling is important, and EC pills has come in here as I spoke earlier to you. Okay, so a little bit detail about the methods, which we shall very, very quickly go through. The barrier method, the condom after abortion, the timing of abortion, as soon as sexual activity is resumed for both first and second trimester abortion. And we don't usually restrict sexual activity after abortion. After the very first period, they usually resume, and we don't restrict it. Only thing is contraception should be ensured, so barrier can be used. Of course, there are no side effects. It can be used without consulting a health provider, available, and it is prevents against STI, and if it is the male latex condom, against HIV as well. And then it puts the ball in the man's court, which is important because it gives him some responsibility of using a contraceptive method. The post-abortion contraceptive method, IUCD. Now, IUCD, anyone can be used, the 380A or the 375, depending on the duration for which the woman is using. These are the devices available in the government, the public sector, and therefore have become part of this module. But in the private sector, we can also use the 250, etc. After the first trimester abortion, surgical, it can be immediately inserted, or medical 12 days after the abortion, ensuring that it is complete abortion. With medical method inserted around day 15 of the process. So 12 or 15 after medical method is quite okay. The first follow-up, provided it is complete expulsion and the risk of infection or other contraindication is ruled out. Second trimester, up to 12 days after the procedure, and contraindications are ruled out. Very, very effective. LARC, long-term contraceptive method, 5 to 10 years, as you can see. What is the eligibility criteria for the provider? Now here there is higher relaxation as compared to abortion providers. This can be provided by MBBS doctors who are trained, graduates. It can be provided by A&M and nurses after first trimester surgical abortions. But after by trained after first trimester surgical abortions, it can be only after by doctors only after medical method of abortion, and by PP-IUCD trained doctors after second trimester abortion. So that is an important thing to know, that those doctors who are trained in PP-IUCD insertions only can provide the IUCD insertion after second trimester abortion. Advantages: immediate return to fertility after removal, no interference with sex, and of course no side effects. What about the hormones? They are invaluable tools of contraception after an abortion because they can be given orally immediately or up to 7 days after abortion using surgical method. With medical method, it can be day 3 with the dose of misoprostol. I have seen many doctors giving them the prescription of miso as well as COC pill, both the medicines within day 15 of the process after confirmation of completed abortion is also acceptable. Second trimester, immediately or up to 7 days after abortion. Okay, so we can be assured that pills can be prescribed, as early as day 3 or within day 15 of confirmation of completed abortion. And in second trimester, it can be given as early as 7 days also. So also on first trimester when it comes to surgical abortion for first trimester. Additional information that it is a beautiful menstrual regulator. You know that COCs are the best method to regulate cycles, and it can be provided by all health workers after first screening by a trained provider. That means a refill prescription can be given by others, does not interfere against sex. It also protects against a variety of other diseases. You all know the list: the ectopic pregnancy, the cancers, the benign diseases, not suitable for women who are lactating within 6 months of delivery, not suitable. What about the long-term injectables? MPA immediately can be provided within a week of up to 7 days after abortion using the surgical method, even in second trimester after 7 days within the abortion. With medical method of abortion in the first trimester can be started on day 3 along with the dose of misoprostol. So that is a good change which has happened in the MEC criteria for the medroxyprogesterone acetate depot. Earlier, it used to be said that it should be after, of some time, but now it is day 3. Very confidential, highly effective, can be provided by graduates, MBBS, Ayush, ANMs, nurses after screening by MBBS doctors and above for the very first injection. After that, other providers can also inject. No interference with sex, does not interfere with lactation, no estrogenic side effects, and of course protects against ectopic, ovarian cancer, against anemia and uterine fibroids. Some say endometriosis also, but that is not very sure. Now, what are the permanent methods? Sterilization, female and male. After first trimester can be performed in the absence of any infection, blood loss, concurrent, or up to 7 days it can be provided. Both mini lap or laparoscopic sterilization can be done. With medical method of abortion, it can be done only after the first menstrual cycle. So that is from the sterilization guideline, that after medical method of abortion, please operate only after the first menstrual cycle. That is different from the contraception. So that is where it is different. Mini lap can be performed concurrently with second trimester or up to 7 days after an abortion in the absence of any infection or severe blood loss. But laparoscopic sterilization is not recommended. Please remember that mini lap is better. The additional information is that it is permanent, effective, immediately, no interference with sex, no effect on breastfeeding, no long-term side effects, offers protection against ovarian cancer. Now the extreme right, additional information is actually a disguise for counseling points. I think you must bring them on as counseling points. If you go on talking about this, the acceptance is better, because these are exactly the fears in the minds of the women and her husband. What about vasectomy? Now, this is the difficult thing. Performed on males, of course, independent of timing and procedure. So even as the woman is getting it done, if the male can be motivated to go and get himself vasectomized, it is fine, very effective, permanent, no long-term health risks. And the only caveat is that the couple must use another method for a period of 3 months till the male can be declared sterile. So with medical method of abortion, COC day 3, injection day 3, any day afterwards, COC day 3 and day 15, centroman day 3 and IUCD on day 15. You can see that. With vacuum aspiration, that is surgical method, COC injectable and centroman can be given simultaneously. IUCD also can be provided. Day 12 onwards, day 8 onwards, other methods are day 8 onwards, IUCD day 12 onwards, and of course tubal ligation can be done concurrently. What about teleconsultation and other digital technology for sexual reproductive health services? Leveraging these technologies will go very far in improving the quality of family planning services. Remember, today we are looking more and more at quality assurance. Teleconsultation, counseling, guidance, reference, and linkage will take us very, very far in our healthcare, and the time for this idea has come, has arrived. There are websites like Hamdo, the social media like Ask Tanu. I'm so happy that Ask Tanu has made its way into this module. YouTube has a lot of information. Infographics are there available. Helplines are available, in patient education platforms, just like Dr. Taide just now showed. WHO, MOHFW, and RCOG, all of them are highly proactive in providing information about contraception methods. So the SWOT of teleconsultation, what are the strengths, weaknesses, opportunities, and threats? It is time we analyze this, and this may be the right time to analyze, because for the past 2 years, all of us have provided this service. So this will be the right time to analyze the SWOT analysis, to go through the SWOT analysis. What is the strength? It has proved itself in the COVID era. Approachable throughout the process, confidence is maintained, awareness, spread out questions, answered at ease. I personally have very rewarding experience of teleconsultation with my patients seeking abortion care. Weakness, there is no face-to-face, and we cannot demonstrate if the woman wants the procedure to be demonstrated on a dummy, or she wants to see the contraception methods for herself. That is the limitation, but it has been overcome by us showing the methods to her across the video. Opportunity, privacy, and this is the important thing, that it gives her privacy. I think she finds it better than sitting in a room where sisters are there, other healthcare providers are there. She finds it more private, saves the cost of travel, etc. She has to pay only for the consult, and the number of visits can be very cleverly cut down if we can utilize the teleconsultation better. Is there any threat to this? Is there any threat? The threat is that there can be a missed opportunity of picking up a pregnancy. Maybe sometimes we miss asking the questions rightly. So a very thorough history taking will help us not to miss any opportunity. neither for picking up an unintended pregnancy, so that the abortion doesn't get delayed, and nor in giving her the appropriate contraception. A misdiagnosis. The biggest fear in the mind of the provider is an ectopic being missed. Again, a very good history taking, a very good follow-up will avoid all this. But any which way, teleconsultation cannot take us, cannot walk us through the abortion procedure itself, because the woman has to come at least once to the clinic in order to be able to sign the consent forms, etc., and for the proper documentation. It will, however, help us immensely for contraception provision. Applicability of components of CAC, assessment, confirmed diagnosis, contraceptive need, counseling, follow-up. There can be hybrid services, one visit, and in MMA, 3 visits can be cut down to 1 visit perhaps. That is how the message is given. The key messages are therefore, realize the need for post-abortion family planning. Remember, this is a most opportune time to educate her on contraception. This is a time when a woman is most vulnerable in her life, when she has to make a very, very important decision, and then she would look for help to avoid being in such a situation again. Bring the couple on board and strive for 100% coverage. Capitalize on the basket, show the basket. The public sector basket also is reasonably expanded today, but I must tell you, in the private basket, there is no dearth of methods. And capitalize on the basket and applicability in the post-abortion period. Technology, as far as possible, root for it, because women today do own Android phones, and they will be able to access, a lot of information. However, some concerns still remain, like how it can make its entry into the highly streamlined CAC services of today, the concern about policies, the fear of malpractice, the cost, and the access. Everything becomes, a little challenge to implement, but then we need policies regarding teleconsultation very, very soon. Adolescent reproductive health needs both online and offline counseling, because probably this is a vulnerable group and requires higher support, and I would recommend both online and offline for them, and continuous partnership with them, and follow-up should be ensured. So registration and pre-test, all of you would have done. Kindly complete the post-test and feedback. Certificate will be awarded to participants on attending the training, submission of all the 4, registration, pre, post, and feedback. So I think that was my last slide. As my previous speakers have said, we all have to make abortion safe and respectful. It is already legal for several decades, but we need to make it safe and respectful. We need to add newer dimensions to this service. Samarth Bharat, Sampurna Bharat hai. Sustain, accelerate, mainstream access to reproductive health through health systems is call of the day. And I am very, very honored today to participate in this webinar and to be instrumental in this. Thank you so very much for your time.
Thank you, madam. There is one question from Dr. Manjusha. She wants to know, ma'am, patient takes emergency contraceptive pills twice or thrice a month. How shall we counsel her, and is it advisable?
Okay, so this is a very common dilemma, because women do try to look upon emergency contraception as an easy way out, because they find that it's easily accessible, it's available over the counter, only rarely prescriptions are needed. And also they feel that, it avoids the embarrassment of going and asking for or consulting. So the correct thing to tell her is that it can lead to refractory menstrual disturbances. If it is used often and she depends very often, sooner or later the method will fail, because she may fail to use it at the appropriate time, or she may become too complacent. So it can result in failures, it can result in refractory menstrual disorders. And then she has to be told that a regular method is the best for her health. And when we add up the doses of progestins like that, when she takes them in several doses, well, we don't know what is the long-term impact, or it has not been researched yet. So using emergency contraception as often method is not a researched thing. There is no research on this, and therefore it is considered unsafe because we don't know the hormonal impact of this repeatedly taking progestin. Apart from causing menstrual disturbances, it may have more impact on the woman's health. We don't know it. So that is something that she has to be told. However, if they are very resilient to ongoing contraception, then probably emergency contraceptive will help them to avert an unintended pregnancy. And we must look at it as something is better than nothing. And if they are very resilient, we can tell them the pros and cons, and we can not saying that it is not advisable. You can give them a prescription when nothing else is possible. Having said that, I think it is also important for them to understand that the ongoing method of contraception will provide less, will give them less risk, and will be, better, because the benefits of other pills, if they are pill takers, then the benefits of the pills, there are so many benefits that we can highlight to them for regular contraception. The other thing which we can propagate is we can propagate the use of intrauterine device as a very strong method of emergency contraception. We can tell them, it has got a larger window, and once we insert, it becomes an ongoing. So with that advocacy, we can bring them on board and insert the device. We can tell them it is going to prevent this pregnancy and future pregnancies. Maybe the acceptance will happen. We have to try every door. We have to knock at every door. Thank you so much. Yeah.
Thank you very much, ma'am. It was a great honor to have all the esteemed faculties today with us. Dr. Basant Mukherjee sir, Dr. Shobha Guli madam, Dr. Pushpa Someshi madam, and Dr. Surekha Tande madam. Now I would like to call Secretary of Amravati Obstetrics and Gynec Society, Dr. Shalaka Bari, to kindly put to vote. Thanks.
Respected dignitaries, I'm very thankful and very gratified for your participation in today's webinar. I request all the participants to kindly register from the registration link to solve the pre-test, those who have joined directly from the joining link. And then before leaving the webinar, please click on the continue button to solve the post-test and solve the post-test for the RAC certificate. I'm very thankful to respected Dr. Shobha Gudi madam, Dr. Somanshi madam, Dr. Basab sir, and Dr. Taide madam for enlightening us on such an important topic and the module. Thank you all the participants for logging in, and thank you Meti Events for the platform. Thank you, Foxy. Thank you all.
Madam, this is Sriman, and I shared the posters and feedback in the chat box, madam. Ask participants to click on the link. They'll redirect to the process of feedback. They have to fill and submit. They no need to wait for continue button. If they won't find the link, they don't need to rejoin in the meeting again. I've posted the link in the chat box.
Okay. Thank you so much, everyone. So I think we can leave now. Thanks a lot. Thank you, Pushpa.
Thank you.
Thank you, Rashmi.
It was nice to have you with us, madam.
Yeah, it was nice.
Thank you.
Hi, Gayatri. Long time since I saw you. Gayatri. She's not there.
Gayatri madam, please unmute yourself now.
Yeah, I think
Yes,
it's okay.
I'm here only.
Yes, Gayatri madam has come.
Yes. Rashmi Puna bol. What?
The Shobha Gudi madam wants to talk with you.
No,
Gayatri
nothing.
madam.
I just wanted to say hello because it is
Hello, madam. I'm very glad to see you, madam.
so am I. Wonderful.
It was a nice presentation.
The module is
It was so
very
wonderful to have all the esteemed faculties today.
okay. So with that, I think all the best, Pushpa.
Thank you, madam. Thank you. Much needed.
Bye.
Okay, bye. All of you.
Bye.
No one is ready to leave.
I think they are solving the post test. Then
Yes,
they will leave.
yes. You can end the meeting from your side, madam.
Hey, doctors, I'm closing the meeting now.